Thank you. And so glad to have a chance to meet so many old friends and new friends and online friends as well. So today I will share a little bit what we have been doing in CT area. And at the very beginning, I would like to thank the funding support and also my team members. If there is any credit, all goes to my group members, team members. If any mistake, that's mine. All right. So let's be clear. So two things I want to share with you. Number one is combine deep learning and CT to extract quantitative CT imaging biomarkers from single kV CT for clinical diagnosis. And number two, I want to really bring this into clinic setup. So we want to establish deep quality check mechanism for deep learning application in clinical CT applications. Let's start with some clinical motivations. So we're talking about is really about the acute pulmonary embolism. Okay, if they not treated, and that will have significant mortality rate as high as 30%. And death rate, if diagnosed and also properly treated, will immediately drop down to 80%. So it is very significant disease to talk about. And the CT pulmonary angiography is currently the preferred image modality for evaluate patients with clinically suspected acute PE. Okay, and the pulmonary emboli, because a lot of engineers and physicists like me here, and this really reflect into the partial or incomplete intraluminal pulmonary vessel filling. So you can see even, for good case, medical physicists like me can diagnose the disease. Okay, and however, the challenge is vessel filling defects on CT pulmonary angiography is not always specific to pulmonary embolism. Can also result from other pathological and anatomical factors such, that will result in the over-diagnosis, as nicely summarized in this JAMA paper. So a lot of pulmonary emboli have been diagnosed because use a lot of more CT applications and a lot of more disease will be diagnosed. But unfortunately, mortality rate drop is minimal, not aggressively. So that is something if people think about, really we need to think about, how to avoid this over-diagnosis. But on the other hand, the New England Journal also published papers, okay, CTA still miss small peripheral segmental dots, clots, and that like to be better diagnosis, such that, otherwise we to go to the nuclear medicine for ventilating perfusion scintigraphy. So the key point here now is, yes, the CT pulmonary angiography can help diagnose PEs, but maybe overdiagnosis. On the other hand, we need them. So what is the key missing factor? The key missing factor actually compared with nuclear medicine is the functional capability, imaging capability. So this motivated our projects in past 5 years also. It's really, we have been thinking really hard how to from standard CT pulmonary angiography, that is what you will see, to try to extract the CT-based perfusion map, such that this map can augment the CT pulmonary angiography to have better diagnosis, to have more definitive diagnosis in the clinical setting, and in some cases may not have to send patient to the nuclear medicine study. But don't get me wrong, that doesn't mean nuclear medicine is not good. Okay, we just what is the best clinical workflow? That is what we're talking about. All right, so this motivates us, in fact, for 5 years to really think about how to leverage the super powerful computational platform offered by the computation capability and the deep neural network and so on to do something to help accomplish that. So that is what we do, try many, turns and failures and finally come to the idea. So we start with really the single KV polychromatic. Remember, it's called polychromatic sinogram. Why? That is projecting data. Generate right now, you do reconstruction, generate grayscale CT images. We send this CT image into a neural network to decompose this image into two fake, material bases. That's a water basis and iodine basis. Okay, but this can be arbitrary because you have one input, you get two output. Definitely, this is not a well-determined problem. So something can go wrong. So that is why we need to bring the physics back into process to educate neural network to do something just like physics allow, not arbitrary. So what we do is we have to send the generated sinogram into to estimate forward projection, generate water-based sinogram data, and then we compare with a single KV sinogram. Because we have raw data access, that is my advantage in the lab. Okay, and all these things we can go to actual color module. Color module is intrinsic to evaluate for each measured projection data because the path length for each detected element, each ray is different. That means beam hardening is different. Beam hardening is different. That means in the measured data, some energy fingerprint is encoded in the measured data. We try to extract that. That is the color resolving module. So there's effective energy map being sent back into the module to try to educate, to train the neural network. We have, both this, and synthesize. After everything get done, and then the model, all the data put together, you should be able to go back to the originally measured data. So we have two constraints, C module, a color module, and a synthetic module, both the physics space, to constrain the back propagate the errors and some back to the color resolving module speed such that we can train the model consistently to generate a kind of image. So the technical detail, I don't have to go through here and paper published, you go into, that 22 pages paper, just goes through all the details there. Okay, talk about ideas. Okay, and there's why it is called Deep-En-Chroma, because that, unfortunately, my son has some color blindness there. So what he discovered is put on this in chroma, and that helps some, resume some kind of color resolving functionality. That is called in chroma gloss. You go to the Google, you can try to figure out, and that is something can do. So that is exactly, that is what I'm trying to do. Is just the grayscale CT images, which send into a deep neural network. We try to restore some kind of color, okay, or dual energy CT-like functionality. So we call this Deep-En-Chroma. So if you're curious, why call Deep-En-Chroma? All right, and that now let's talk about validation studies. And we start with the hardware-based dual energy CT that indeed provide two material basis images, iodine image. And then we take the dual energy CT data, the high energy data set, just one sinogram with send into our trained Deep-En-Chroma to generate water and iodine basis images and evaluate, whether the Deep-En-Chroma generated water iodine basis image versus the dual energy CT results, what is the difference, and so on for different patients. We can go through that, and it is not perfect, but more or less, error is very small, and we evaluate this just like you and publish paper. We evaluate about 10, 20 cases. You can publish paper. Of course, we can from there. We can also extract for physicists to identify, to specify a specific material. It's not about the iodine basis image or water basis. It's about atomic number, right? It is atomic Z and also electron that specify atoms. So that is why it is important to extract the effective Z. And for the Deep-En-Chroma and of course the dual energy CT, and you can compare the difference, and also the difference is insignificant. I cannot say it's zero. All right, and now let's really go through from one case, two cases, not enough. Let's go through about 10 cases. So that is really the iodine basis image. The rest really the hardware-based thing. We do the blend order analysis. You can see the bias is close to zero, and with this, the 95% of the agreement is there. It's quite nice. All the data essentially just fall into this 95% confidence interval. And not just one is not enough. We can go through, many cases in one institution in our clinical site, and that is, you can see the center of the population-based the error. You can go through, more than 150 cases in this case, and then it is always consistent within that range. And that is for water basis image. You can also do that even better because it is relatively flat and easy to do that, to do work, and the consistency is quite good over the one clinical center. Is that good enough? No, not enough. Okay, from one clinical center, really have to apply the model, train the model to different clinical centers to see where it works. And that is what we did. We, work with Henry Ford healthcare system, and they send the data and we'll process. So far, we processed about 74 cases. And again, the error bar is slightly increased, but not outrageously large. So it's quite consistent. That made me quite happy. Okay, and also in this case, we talk about, we have an AI model. AI model could be biased, against the gender, could bias the race, and so on. So we have the large data cohort back there, and then we retrospect with to see whether we can do the subgroup analysis to see whether the AI model indeed is biased toward gender. And for example, somebody have the big BMI, somebody have the small BMI. We check that, and female and male and p-value is, really does not show the statistical significance between the biased two groups. And by BMI larger than 30, smaller than 30, and does not show the significant difference. Okay, that is all good. The next thing is, okay, with the generated the fake, the ZF and so on, let's generate quantitative biomarker. And then that is in my group, we develop a score, a quantitative called the Z-score method, and details is right there is directly from the extracted effective atomic numbers. You have a beta there, and then really that is the contrast injection, the original normalized by that you get the proper quantitative biomarker. You can use that Z-score to evaluate pulmonary, the functionality. So that is what we're going to show here. Single KV Z-score really generate lower part, for example, this subject, and lower part perfusion defects, something perfusion defects there. If you something, body will say, well, in clinic, your energy will have the iodine image. You can do so, but that is not specific at all because everywhere just uniformly enhance the iodine. So because of the specific pathological structures will have a lot of confounding factor, and we put this way in iodine image. But in this score, it's much more specific. And this you can compare with nuclear medicine studies. You can clearly see there's a mismatch between the V and Q images. So that really shows the bottom part is perfusion defect. So that is what we see using the single KV Z-score, and you can indeed do something nice in clinical environment. And also whether that is specific enough, of course, when you see there is a perfusion defect, really that help my radiologist go back to check carefully whether there is a perfusion, filling defects or not. That is easy. This is big chunk, so easy to find that one. Actually, I find this one, okay? So that is easy to do things. And then, if you use iodine map, it's really nothing specific there. A good method, not just be sensitive to pick up something. And for healthy case, you should be able to say, okay, no, it is specific, there no perfusion defects. This is another case is really, we do not see any perfusion defects. And nuclear medicine indeed confirmed there is no perfusion defects. So that means that this score is a good thing, can also go through many other cases. Okay, so good, that is for PE studies. Now you have a kind of understanding with, use single KV image, extract some dual energy like, I never claim it's dual energy, okay, like image, you can do something clinically useful. And what else can we use? As long as you have material basis like image, actually can create so-called virtual mono energy image to boost contrast. For example, single KV, you see the contrast is not nice enough, and you do the Deep-En-Chroma, the virtual monochromatic at 45 KV, you can clearly see the contrast get boosted. It's that much easier for clinicians to identify the filling defects and so on. Okay, and you say, why do you care about that? Okay, so you think a little bit back to last year, right? If you work closely with radiologists, last year is a big year because a lot of CT contrast agent actually manufactured in Shanghai, but due to the COVID policy, Shanghai government locked down entire thing. So basically create a huge crisis in the contrast agent supply thing. So that is why a lot of clinical papers start to address this. Now you see, and because of that, my department immediately sit down with me to say, okay, can we immediately deploy this Deep-En-Chroma VFE to clinic to help us reduce the contrast media, because on shelf, in stock, we don't have that much contrast available any longer. So that is, scientists, we can do something to help in clinic. So the final case I want to share with you is the abdominal studies. You also generate virtual non-contrast CT image for lesion characterization. So this is the case, abdominal case, really, this is large patient, and from single KV image with contrast, and you can generate non-contrast image. That is for technical point to make. It's really the calcification at the aorta is really tiny, teeny small. Quite often when you remove the contrast, the iodine also get, if you remove iodine and the calcium also get removed. But nice enough, our generated method nicely keeps the whole thing, not just in one slice and consistently for the whole volume. Okay, and you can compare with the two non-contrast, you can compare, compare the CT numbers from true non-contrast versus the virtual non-contrast. That's consistent. Okay, it is quite Nice. And he said, what do you use? Why do you need the virtual non-contrast CT images? That is a nice killer application, really make my abdominal radiologist calibrators proud. It's using the single page generated spectrum CT that without contrast, that is a clinical case. And what she discovered is right at the, the glandular and some mass being discovered. And she mentioned the number, CT number is about 52 HU. And 52 HU really put her in difficult situations. That is a benign or malignant mass there. She does not know. So then in this case, they have to order, send this patient to MR and really to have the out of phase, and you can see the signal drop there, and that make radiologists feel confident. So, okay, this is a benign case, that is easy. But if we really have this patient who have the technique available and generate iodine basis image, and then we can really compare virtual non-contrast CT image, really tells this by the knowledge actually the CT number is just around 0. If it's around 0, that essentially, they are so confident it's just a benign case. You don't have to go through the MR, but again, that's not MR is not good. It's just the clinical workflow. You facilitate clinical workflow. That is a key point I'm making. Okay, in 5 to 2 minutes, I trying to tell you, okay, you have model developed, everything looks good. Is our life just that's it? You just directly apply everything. Not quite. For all the deep learning method, that is at least my philosophy, we need to have a quality check in place because you train, validate that everything is good, but you apply to clinical setting. How do you know the clinical future prospective population will be the same as what you train? That is not good. We need to have the QC in case. In our case, we send the material basis image in a QC module, and that will really generate the error map. And we can overlay the error map to the original CT image to tell my radiologist which part of the AI prediction or deep learning prediction it can trust, which portion in the image, the generated material image is nonsense, don't trust that. Okay, we'll overlay that, and that is the map in the map right there, and then they'll feel confident. Okay, so that is what do, for example, good case, you have some bones and the deep QC generate errors, they just overlay and they take a look, say, okay, this part, whatever AI say I don't trust, let me use my human intelligence to make judgment call. Okay, and that is a good case. In another case, for example, misdiagnosed some, the calcium and so on. Then you just tell AI, just overlay that thing, so, okay, this part don't trust. That's it. And then you say, okay, in the end, they say, what else can you do? They let me, I always want to challenge my team member and the students. I say, okay, I ask them, everything is good, because so far error is small, but let me create a really strange situation for you. I say, here is a Longman phantom. It's a physical phantom. Let's put 2 insert, physical insert. One is iodine water mixture. The other one is calcium. Okay, that adjusts the concentration of iodine 2, such that the CT number of this 2 insert is exactly the same. In this case, you do the decomposition from single CT image. Definitely we know it must be wrong because nobody can really differentiate 2 CT numbers can generate 2 different kind of material composition. That is well known. So that is deep QC will kick in. Okay, indeed, no surprise, of course. It is a phantom. We train everything on human subject. How do we expect it works for phantom? Not quite. But good thing is AI, the deep QC model, indeed tell precisely what goes wrong and overlay the image, just tell me, okay, these blocks don't trust because your Deep-En-Chroma model just generated the wrong results. So this one, when I talk to at least my clinical folks, and everybody looks okay. So that you make me feel a little bit comfortable now, okay, when I apply things. So that is basically what I would like to share with you and take home message, and 3 points to make. And number 1 is we say we are optimistic deep learning method indeed can be used to retrieve the otherwise lost quantitative information to enhance clinical diagnosis and facilitate clinical workflow. Number 2, imaging physics can be and should be incorporated into the deep learning method to provide the desired quality check in AI applications. And that is, we show a case, at least for 1 example, with QC model can be trained, developed to help our clinicians to have some confidence about the Deep-En-Chroma model. That said, I thank you and take any question if you have.
Hi, Guang-Hong, very nice work. So I have one question about the DeepQC model. So is it possible that your generated iodine map and water map are wrong, but the DeepQC model still like the error is 0?
Could be because you have two input, because two material basis image that is being combined simply in single energy case, just combined. So you have one error is positive, the other error is negative. These two, yes, potentially can be canceled out. So does not show up there. Okay, so you do have some false negatives there. But the good thing is, wherever there is error, the error is there. The sensitivity is there, but specificity in this case, DeepQC is not perfect yet. That is indeed the case. Yeah.
Thank you. Yeah, I try to debate with Chen Guang-Hong about 0. We are in physics, we don't like 0. Only mathematics like 0s. Okay. Physics, I don't like 0. Okay, so you have 0, you just continue to scale. Try to avoid 0 in physics. That's my comments.
What does that mean? Avoid 0, where did I have 0?
Yeah, someone put up 0. I think in physics, 0 comes at least 0. So 0 makes sense in physics. And avoid 0.
Okay, thank you. But how does that relate to my presentation?
You can drop prediction wise go up down for 0, right? So 0 you try to avoid 0. That's it.
I don't get
You
it.
guys can talk out.
Yeah, I don't get that.
One
Thank you.
question.
Yeah.
Save time.
Yeah. Mhm.
Hey, Guang-Hong, nice work. So one question about when you have the water sinogram and the iodine sinogram, why do you need a deep learning network to compute a single KEV or KVP sinogram? You can do it analytically too.
Oh, that's good question, Bruno. Remember, GE makes scanners, Siemens makes scanner different. And from two material bases, just like our body composition. Our body composition being sent into scanner, and the scanner actually contaminate all the electronics and the physics, everything, everything contaminated the data. So if you just do simple combination, then you use an idealized model to generate sinograms, so always have error. So that is why we need a physics, fully, a model, scanner model to simulate all the data goes in physics. Okay, make sense? Great.
Thank you again.
Yeah.